terms of our third case, we have a 5-year-old male who's having pain, erythema at the mid-plantar foot region. He has a fever and he's not weight bearing, and he's been on Caflex and he's not improving. When you're actually assessing him, he has erythema not only at the site but also tracking from the site, edema, and he's tender. And maybe he was on the porch without shoes the other day and went swimming. They're not sure. He might have stepped on something, maybe not. So here's another example of a water bath. Do you guys see anything? Not a point? Yes. Absolutely. So what do you like? What drew your eye there? What made you think there's something there?
Hyperechoic line with the reverberation.
Does your cursor come up when you?
No. Sorry, people at home.
Later, I figured out how to change that. It's or but yeah, later.
Yeah, right. So this is a wooden splinter. Ended up being 0.7 centimeters in size, about 1 centimeter below the skin surface. Overlying, there is a little bit increased echogenicity, but there's no abscess there. So definite foreign body inside the foot. That was well visualized with POCUS. And you're seeing, you're right, you're seeing like this linear structure that's hyperechoic. You're having shadowing behind, maybe a bit of reverberation down as well. So here's another view in a transverse view. And it's a lot harder to pick up here. Can you guys see where it is? What's the point? Here? Yeah, right there. So you can see how that'd be really easy to miss if you were only doing this view, only doing the transverse view and not doing the long view. So really important to do the two because it will help you pick this out. So in the end, this child was admitted to plastics for IV antibiotics and surgery. Blood work all came back normal. Just another case in terms of foreign body. So 8-year-old female, let's say sewing needle, broke into her finger when she was sewing. She has pain, swelling, and decreased range of movement of the fever. That's the finger with no fever. She's got erythema tracking from the site. She's got edema and tenderness as well. And so this is what you do, what you see when you first put the probe on her finger. Can you guys see anything? What do you think this is right here? You're on her finger.
Bone.
That's her bone. You're right.
But then is it the joint on the middle?
That's the joint in the middle, absolutely.
And then the nail here?
Yeah, and the nail up there. Do you see anything?
No.
No, so hard to see. What about now? So you can see how your visualization in the water bath is so much better than trying to put your probe on the finger. So this is an example I just wanted to show you to show how much easier it is to see in the water bath. So always think about your water bath when you're looking at extremities. So you can see any foreign body, nothing hyperechoic.
Right here. No, I don't.
So it's definitely challenging. I will tell you the only way that I knew exactly where this was because we got an x-ray and I knew where it was, and then I went and looked. So it's actually sitting right here at the very tip of her finger. So you can see the bones, you can follow them up, and then so they're hyperechoic. And then at the very end, there's something that stays hyperechoic at the very tip of her finger that's not part of the bone. So that's actually the sewing needle inside. Very easy to miss.
Mm-hmm.
So definitely with something that is known to be radio opaque, getting an x-ray is always still helpful. So this one I wouldn't have known. I would have potentially missed. Like, obviously we saw it, but it's only because I knew where I was looking. This is an example of wood. Where do you guys think the foreign body is? I see you're making a gesture.
Or the shadow.
The shadow, yeah.
Here, right?
So sometimes you're not going to see the foreign body. You're just going to see other things. You're just going to see posterior shadowing. You might see posterior acoustic enhancement. You might see a halo sign. You might see a ring down artifact. You're not always going to visualize the foreign body. which is what makes them a little more challenging, especially the ones that are not radio opaque. So here, there's a piece of wood. Maybe you would see that little part that's hyperechoic. I think that'd be very easy to miss in the rest of the soft tissue that's heterogeneous and has parts that look like that, but you're not going to miss that acoustic shadowing behind. Here's another example of wood. Looks a lot different than the other one.
There's no shadowing.
There's no shadowing in this one. So they always come up differently. It's not like you can say wood always looks like this, metal always looks like this. They're all going to be a little bit different. So you want to use all of those things together. So you can see the straight line, hyperechoic at the very top of the screen. And so that's your wood foreign body. So on the left is glass and on the right is metal. So when you're looking at this, the very top of the screen in the center, you're seeing something hyperechoic with a bit of reverberation behind it. So that is your glass. And then on the right is your some sort of metal in a soft tissue, and you can see the reverberation coming down and then a needle coming in to meet it. So foreign bodies can look different. Think of all your signs to look for them. So in terms of some of the evidence, there is a lot of evidence out there. A lot of it has been done in cadavers, especially the point of care and the radiology literature. So in terms of the size, your sensitivity will increase as the size increases. So this was seen by Jacobson et al. In 1999. That basically had wooden foreign bodies in cadavers. This was done by radiologists. They had 2.5 millimeters times 1 millimeter length, and the sensitivity was 87%, specificity 97%. When they went up to 5 millimeters times 1 millimeter, the sensitivity was 93% and the same specificity 97%. So improved sensitivity as they get bigger. So Orlansky in 2000 had a prospective study that actually looked at emergency physicians versus radiologists versus techs and seeing how good is everyone at finding foreign bodies. And it turns out that we are all equally good. There was no statistical significance between the three. So they actually used chicken thighs, and they had radiologists, emergency physicians who were experienced in ultrasound, and some ultrasound techs. And as you can see, the accuracy is roughly the same for all three, and the sensitivity is roughly the same as specificity for all of them. So therefore, emergency physicians who were trained in ultrasound can be successful in finding foreign bodies. Tucker et al. In 2006, in the academic journal, the American Journal of Emergency Medicine, they had a randomized, blinded, descriptive in vitro study that compared plain radiograph. So they had plain radiograph versus soft tissue X-ray versus ultrasound for non-radiopaque foreign bodies, so wood and rubber. Basically, they used X-rays versus ultrasound. They also had chicken thighs, and overall, the the ultrasound was much more sensitive than X-ray, but they were both specific. So overall, ultrasound was sensitive 90% versus 5%. 5% is horrible for X-rays. For the radiolucent, and the specificity was 83% versus 80%. So ultrasound is definitely better than X-ray for the radiolucent foreign bodies. It doesn't take I think a study was needed to show that, but also you would expect that because they're radiolucent. So Davis in 2015 in Academic Emergency Medicine, they had a meta-analysis for diagnostic accuracy of ultrasound and POCUS for soft tissue foreign bodies. Of note, they only had one POCUS study inside of this, which was a pediatric study. The reference standard was either a CT or surgery, or follow-up to see if the patient became asymptomatic. Overall, they had 17 articles included. The sensitivity pooled was 72%, the specificity was 92%, with an odds ratio of net of 29. They did do a subgroup analysis of radiolucent or wooden foreign bodies with a sensitivity of 96% and specificity of 87%. So overall, ultrasound is highly specific and moderately sensitive for foreign bodies, and it's overall been shown to be better than X-rays. So in terms of tips and tricks, you can potentially see your foreign bodies with direct visualization. You might not. Other things to look for: halo signs, ring down artifact, posterior acoustic enhancement, and acoustic shadowing to help determine where your foreign body is. Ultrasound is better than X-ray, but it cannot rule it out at the same time. So if you still think one is there, then you need to use other adjuncts or refer them on to plastics or surgery for further assessment.